Hi, my name is Gregory Mark. Today's subject is biological shaping discussion. One of the doctor posted the case where he had the complication after doing verteprep. He done multiple cases, and this particular case, when he doesn't know why that's the crown when he placed um, having a kind of reaction from the tissue. So today I want to just point out some of the clinical tips when we're trying to do biological shaping, or we're trying to do like a verteprep, what we have to probably pay attention, especially when we're prepping the teeth. So in this particular case, let me show you. So that's what original picture. Again, I don't know what the sequence of the treatment, but I just was guessing that's what probably would happen to this particular patient. So you can see it's number 14, or it's I don't know which tooth. So it's number 6 if European style. So it's a first molar. And you can see it's a little bit positioning more palatal compared to adjacent teeth. You also can see that the tissue also on the buccal a little bit inflated. I'm not sure, it's again just a picture. Again, what I see so far, a little bit like a redness or inflammation around the buccal. So if we going to look at the preparation, you can see the doctor been trying to do like a verteprep, very good preparation, smooth. There's no steps. But what we've been trying to do is to go a little bit deep into the sulcus, and what you see so far here, that's in the proximal area, especially in the distal, you will see that the patient still has inflammation tissue on the distal. Okay, you're trying to remove this tissue, so make sure it's when the patient heals. It heals with a nice keratinized gingiva coal. But the most important for us is to see that we have the problem right here. That's what he developed the problem in the buccal. When we do vertical preparation, especially in the buccal, the anatomy, especially in the molars, we have a bifurcation area. When you go deep, this area of the bone is not flat. In the bifurcation area, it's usually in biological width, it's going a little bit opposite. The more you go deeper, the higher the bone, especially at this area. Okay, and that's why most people making a mistake. They're trying to probably reach deep and make this area flat. So what you have to pay attention to, that's the anatomy of the bone. And this bifurcation area, again, the bone is usually located more higher than in line angles. So that's why when we're trying to pay attention, we have to pay attention to this particular area. And I'm going to show you this in just example when I did the surgery on the patient, so you can see where the bone locates. You have to probably avoid this kind of problem. So if the doctor been trying to put the cord, so make sure he displays the tissue before he will take the impression. But you can see how the tissue been beaten up, especially interproximally. So that's the tissue healed when he probably tried to put a temporary crown. But you see still at the interproximal area, the tissue is not healthy. And if you see it from the buccal point of view, it's if you look at this tissue, that's what most people are making a mistake. It looks healthy, but it's not mature yet. It means that the tissue is not developed yet. There's no biological width developed completely 100%. There's no developed connective tissue and epithelium and junction epithelium here. So if you can see here, it's on a palatal, it looks fine, but buccally especially there's a creeping tissue, and the proximal it's not even healthy. When you look at the temporary looks perfectly fine, there's nothing wrong with it. But if you look at the crown, again during the insertion, it looks perfectly fine, but what you see here, is again, as the tissue was not mature yet, we're trying to assume that we can still go under the gingiva subgingivally and placing the crown, but at the same time we're going to violate biological widths. Secondly, you can see how the interproximal, especially on the distal, the tissue is a little bit displaced because the crown, the margin over here, it's impinging into the tissue and doesn't let the blood supply to go in. And you can see that the final result, it's in a few months probably after, the patient come back and you see the tissue reaction. So you can see the tissue reaction only from the line angle to the line angle. You can see on my arrows, I want you to pay attention to them. But also you can see where the bone is impinged right here. So if you just are going to reflect this flap, you will see that the bone, especially in bifurcation area, it's very close to the margin of the crowns. And this crown is going to be overhang over that bifurcation area, which causing this biological width violation. So why is it happening at this particular patient? Again, the anatomy is very different from one patient to another one. Nobody knows why we violate biological widths every time we do the crowns, and the tissue looks healthy, but at one point in posterior, it looks not like in this particular patient. We're more certain, especially on anterior restorations, but not in posterior. But in this particular case, you will see that the crown is too deep into the bone, and that's what's biological width violation reaction in this particular case. So what I want to go through is my case, but before I start, I want to show you what biological width looks like. So not everywhere that we have like a 2 millimeters of biological width. You can see on the left side of the diagram, that's connective tissue 1 millimeter, epithelium is 1 millimeter, it's sulcus. So it's 3 millimeters. All depends how much connective tissue you have underneath the epithelium. And depends on the connective tissue, how much. You might have the same 5 millimeter pocket, but the reaction and the treatment in this particular patient is going to be different. So for example, if I'm going to put a crown up to here on both sides, okay, so the same position of the gingiva, but the connective tissue is different on both sides. Here I'm going to have a normal reaction, but here I'm going to have biological width violation because we're impinging in the connective tissue attachment. So what you have to do is we have to see how much connective tissue by period probing in this particular case. So we have to feel the resistance. When you feel the resistance, it's most likely you're in the connective tissue. You're going to penetrate the junction epithelium through the sulcus. So in this particular case, you also have to probe the bone. Okay, so you have to probe the bone when the patient is numb, but you also have to have resistance to make sure so how much connective tissue to determine, so you know, so what's your limitation, your preparation limitation, your port limitation, and your taking pressure. But in biological widths, it's a little bit different. Shaping. So let's go with this particular case. This is number 19, or again, the first mole on the mandibular. It's the same concept. Same concept. So you can see that's how the anatomy, how the temporary going to react, how the tissue is going to respond. So this is number 19. It's class 1-2 bifurcation area involved in this particular case. There's an inflammation underneath this particular crown. So if we're going to go through the video, you can probably see the steps of what you have to pay attention. I'm going to go slowly to give you those clinical tips. So we're removing the crown. So the crown being removed, and now you can see I'm trying to obliterate all the crown preparation margins. I want to make sure there's no preparation margins exist. So I'm trying to get like a knife edge or a vertiprep on every on 360 degrees. In this particular case, the patient has bifurcation area involved also from the lingual. So I have to shape, biologically shaping also the lingual part besides the buccal part of it. Okay, So I remove all the decay, all the roughness, all the margins, okay, and I use Waterlase I Plus to devitalize the area, but also to reflect the flap. You can see that I'm trying to reflect the flap on the medial and distal areas. Okay, so the Waterlase in action, and I'm trying to again open up the flap, and you can see there's a full thickness flap, but I also see still attachment of the flap on the buccal area. Try to remove all the granulation tissue, especially in the proximal area. But you see the bone, so I'm trying to remove this positive architectural bones to make sure it's a smooth margin through transition. And you can see this. I'm trying to eliminate bifurcation area and try to prep tooth structure from a line angle to a line angle to create the area so the patient can clean the area and not causing the inflammation. So you can see it's again the area being reflected, the bone being shaped, and trying to put chromic guard sutures on both sides and just to close the flap. The second step of it, you can see from the buccal area what the preparation looks like. So what we do is you can see to put a temporary crown. The temporary crown is not supposed to even touch the gingiva. So you can see from different perspective, it has to be away from the gingival margin, and you're going to see it on the next slide. So you see this is a prep. Okay, so I put the stitches, got the hemostasis, and there's a temporary crown, as you can see, far away, just a millimeter away from the margin of the gingiva. Why? Because the biological weight still has to be created. It has to mature. I have to give it space to the tissue to grow back again and make it healthy. If my crown will be right here, it will be impinging on soft tissue, okay, and cause again inflammation. So it has to be 360 degrees, millimeter at least, away from the margin. The crown has to be cemented on a Duralon because it's bactericidal material. It's also making less sensitive preparation. And just in case if this crown will be dislodged or lost, the Duralon will still stay on the tooth structure, making it less sensitive. But you can see that even after 4 weeks, the tissue really start creeping and start making it healthy. This bifurcation area being involved. If you look again, in 3 months after it heals, the tissue is perfectly healthy. There's keratinized gingiva, but look at the proximal. It's completely healthy. Okay, and now at this particular moment, I can take the impression, or I can scan if I do digital dentistry, but my crown is going to be equigingival. It's not going to go down to the gingiva. And as you can see here, the gingiva is perfectly healthy. The crown is perfectly shaped. So there's the groove and bifurcation area, so the patient can brush and clean, eliminate the plaque, the area, especially in this area. This is a final X-ray. You can see perfectly fine. It's that the margins are perfectly fine. There's no steps. There is no inflammation around the tooth structure, and patient is happy just to maintain tooth for long as it can be done. So hopefully you can go back again to this presentation, look at the tissue, look at the preparation, what's supposed to be done. Okay, so the takeaway home lesson is do not put your margins, okay, your preparation below the gingival level. You have to create it, you have to make sure there's anatomy, that's the bifurcation area, the bone is getting higher if you're doing a crown lensing procedure, and you have to just put this in consideration when you do the final restoration. Put a temporary crown 1 millimeter away from the margin of the gingiva to let the gingiva heal and biological width and creation of biological width. Okay, you have to wait 3 months until it heals, and then you can take a final impression. Okay, so hopefully this case will help you just look at your case a little bit differently. Try to approach these cases, and again we can discuss it again. And if you want to go a little bit more deeper on this type of preparations and on discussion on period prose relationship, our class is going to be hands-on. It's going to August 3rd this year, and we're going from 9 to 5. It's going to be a hands-on course. We're going to discuss in details biological weights, especially biological shaping, aortic extrusion, crown lengthening, phatic sign development, PT partial extraction technique, and many more clinical tips and tricks. Hopefully I'll see you there. Thank you.